a little longer. Um, okay, so our next speaker is Dr. Deepa Sannidhi. She's a board certified family medicine, obesity medicine, and lifestyle medicine physician at the University of California, San Diego. She's trained in preventative medicine. Dr. Sannidhi helps people prevent and treat disease through lifestyle and integrative medicine. She is a leader in applying the 6 pillars of lifestyle medicine and developed the SLIM program, which uses virtual shared medical appointments and food as medicine principles to support weight and diabetes management. Her work emphasizes that while newer medications are powerful, they're the most effective when combined with sustained lifestyle change, especially in communities with higher risks for early onset diabetes. Thank you so much, Dr. Sannidhi. Did you want to stand at the podium or do you want to just hold it? Okay.
Yes. Thank you, Nalini. That was a much better bio than I had given you. So yeah, it's a privilege to be here. I'm at UC San Diego, and wonderful speakers so far. Just an incredible symposium. So thank you to the Arogia Foundation for having me here. So these are my learning objectives. Just my role here. Really, what I've found, I end up doing, or why I end up coming to different places to speak is, we have these new medications, the incretins, and there's just been a revolution in the way we're thinking about weight and lifestyle change. And so the question is sort of like, where does the lifestyle change fit, and where do these medications fit, and how do we bring all this together clinically? And that's kind of what I see my role as. So that I have various roles at the at UC San Diego. And so first, to contextualize this, I want to talk about what the definition of obesity is. So it's a chronic, relapsing, multifactorial neurobehavioral disease, and increase in body fat promotes a lot of things, right? So basically, obesity is a disease with many, many causes and many, many effects. And so we often think of obesity as this like, heart disease causing thing, diabetes causing thing, but really obesity is in fact quite global in its effects. And so this is why we call obesity a disease. It causes things like idiopathic intracranial hypertension. It causes things like polycystic ovarian syndrome. So this is why we think of obesity as a disease. And obesity has a definition, and that definition has been a subject of debate and change, because what happens when you say somebody's body shape is a pathology, right? That's there's a lot of there's a lot of implications to that. So there's been a discussion of this concept of when obesity is risk. And this is from the Lancet Commission on Obesity that recently occurred. And so they kind of said obesity is risk, so preclinical obesity, and then obesity is disease, where there are symptoms and signs of organ dysfunction. And what they do is they incorporate not only the BMI, which we know is a flawed indicator, but also the anthropometric measures that kind of focus on the gut fat deposition, so waist circumference. And of course in South Asians, we really need disaggregated cutoffs. So 23 BMI for overweight, 27 for obesity, and Asians as a whole, and there are separate cutoffs also for waist circumference. So you're going to see more and more of this. I always think about this as an equity issue when we talk about waist circumference, because sure, we know we're South Asian, but what happens when you have someone of mixed heritage, for example, right? So we really need a measure that looks at the waist, or that increased subcutaneous fat. You can't talk about lifestyle change really without talking about weight stigma. You can't talk about obesity without talking about weight stigma. And weight stigma has been something that's been of a conversation in the United States, but actually it's a global phenomenon. It's been looked at in many different ethnic groups. And we might think it causes misdiagnosis of diseases, because that bias that we might have might cause a physician to attribute health conditions that are related to other causes to somebody's weight. But also, you would think that maybe the shame from having excess weight would drive somebody to eat less and exercise more, but in fact it is the opposite. And not only is that the case, it also causes people to avoid healthcare. So things like fewer colonoscopies, fewer pap smears. So it's a dangerous thing, and it's something that we should be fighting against. So there are lots of things that we can be doing, but it's a larger conversation. But I will say, people first language is very important. So person with obesity, not obese person, very very important thing to do, and also just really having environments that set people up for success. So and exercise spaces and clinical spaces that that provide that have enough the right gown size, the right chair size, things like this. Okay, so then I'm going to talk a little bit about what lifestyle medicine is. So lifestyle medicine is this field that, one of my certifications, and it's this field that basically says, well, lifestyle is the foundation of treatment for most chronic diseases. It is the first line of treatment for many chronic diseases, but that has not really been operationalized. And many physicians actually don't really feel very comfortable using diet, exercise, sleep, stress, social connectedness, and risky substance avoidance, and using those things in patient care. And how does that happen? What does that translation look like? So so that's what the American College of Lifestyle Medicine exists to do, is to actually, increase the uptake of those things. But it's driven by a lot of research. And so, I suspect many of you in this room know what the diabetes prevention program is. And so, this is and in case you don't know, it was based on a research study in 2002 that showed 58% risk reduction for those who had prediabetes to progressing to type 2 diabetes. It laid the foundation for a CDC-run program called the National Diabetes Prevention Program that is in fact covered by insurance because because it showed that improvement. It was so effective, in fact, that the study was stopped early, and then all three arms, the placebo, metformin, and intensive lifestyle intervention, were then given the lifestyle change, and then those people were followed over 22 years is the most recent data that we have, and there's another decade or so following. Dr. Kanea's colleague, Dr. Araneta, who's at UCSD, is a PI on that, a site PI on that. So it's their goal is 5% weight loss, 150 minutes of moderate to vigorous physical activity. And what's interesting is after that 22 years of follow-up, we really started to see convergence of those various groups. And now at this point, you don't really see that diabetes prevention benefit after 22 years of all those people having been given that initial lifestyle change. But you do see persistent diabetes prevention despite near complete weight regain. That's interesting to me. From the DPP, yes, yes. So other unexpected findings in the DPPOS. So extensive out of so why? Okay, so why were there these low CVD? I mean, why was there no difference in the CVD rates, right? So there was in the lifestyle intervention group, there's actually lower use of statins and diabetes drugs. And so talking about GLP-1s, it does make me wonder, like maybe there's this therapeutic inertia. We ought to have given those people, and I have patients who I've seen this play out. I want to focus on the lifestyle. I don't want to take the statin, right? So we need to be aggressive with cardiovascular risk reduction. And also important to know, DPP was not powered to detect cardiovascular disease outcomes. Dr. Kanea pointed out that DPP was not as effective in South Asians, unfortunately. And there were multiple studies. So this is the Indian DPP, about 29% risk reduction, 26% risk reduction. Informally called DPP2, we had 36% risk reduction. This group was followed for 5 years. We had 30% risk reduction at 5 years. So I think that's non-trivial, even though it's not as effective, right? And then there are multiple other, however, interestingly, when these studies were made larger, you had 11, 12% risk reduction. So, lower numbers there, right? So, I'm not going to beat this to death. We've talked a lot about lower beta cell capacity, but basically, we have limited capacity for subcutaneous fat storage, and then that causes fatty deposition in other organs, fatty deposition in muscle, fatty deposition in pancreas, fatty deposition in the heart, fatty deposition in the liver, very importantly. Um, so DPP, many of you have heard of. Look Ahead is another very large study that informs our, it's based on the diabetes prevention program curriculum, 7% weight loss, 175 minutes of moderate to vigorous physical activity. People were treated, actually, those who didn't achieve the 5% weight loss, they were given Orlistat, which is a weight loss drug. And this also did not show cardiovascular benefit, unfortunately. So, okay, what do we make of this? Should we not give any lifestyle intervention now, right? So, when you look at the sort of the poor self-reported general health folks, they basically were the ones who rendered the study neutral. So if you look at the 85% of the study population that had good self-reported health, they actually did have improved cardiovascular disease risk reduction. And those who interestingly lost greater than 10% of their initial weight reported 21% reduced mortality. So, there's a mortality benefit to lifestyle intervention. Other lessons, 11% for whom prediabetes remission was achieved, so normal glycemia, you had a risk of cardiovascular disease, death, and hospitalization by more than half reduced. And fewer medications. You had the same risk reduction as the control, as metformin on fewer medications, right? So imagine if we had provided that medication, in addition to the lifestyle. And yeah, so I'll stop there because in the interest of time. But pounds lost study. So this is just like Diet Fits that Dr. Gardner was talking about. Really confirmed. This is an older study that really it's not the macronutrient breakdown. It's very much the adherence, in fact, that matters the most. So what is it? So this is now we're starting to get into this area of what does an effective lifestyle intervention look like, right? And when we look at these lifestyle change studies, large lifestyle change studies, what can we expect? About 4 to 6% weight loss. And, in general, we say 5 to 10% expected weight loss. So when, it's really, when we're talking about lifestyle change, we do not want to talk about testimonial level lifestyle change expectations, right? With weight loss, we want to have realistic expectations with lifestyle change. So these inform recommendations. So the United States Preventive Services Task Force is our gold standard for preventive services recommendations. And the last recommendation that we have around this is from 2018, their statement in 2018, which is under review at this point. So this is giving us, this says that, anyone who has a BMI of 30 and above, so for us, BMI of 27 and above, refer to intensive multi-component behavioral interventions. So what does that look like? And there are other recommendation statements as well that say that we really ought to have intensive lifestyle intervention for people with various health conditions, including those with impaired glucose tolerance and cardiovascular disease. This is, just kind of looking at different ways of, what are the different indications. And for South Asians, okay, what does that look like? This is a very small study, actually, the SHAPE study, 17 people. But what I liked about it is, besides the fact that 55% of the 17 people that they had regressed from prediabetes to normal glycemia, what they did is they actually used focus groups, and they did some community listening to tailor the intervention. So, I love the fact that the South Asian Health Studies has been, doing this in an iterative fashion. But, and they've been doing a lot of what Dr. Kanea was talking about with regard to the diet, right? Like reduce the ghee, reduce the white rice and things like this. But also physical activity, they elicited from the participants that these people lacked a baseline. The participants felt that they lacked a baseline exercise habit. And they needed foundational instruction, foundational kind of guidance to improve physical activity. And for women, there were expectations around modesty, lack of access to women-only exercise spaces, and competing family caregiving priorities. So they did have an improvement in their physical activity, and they also addressed body image, food and social roles in community settings, trying to bring in, all these things. So this is for this is for South Asians. In general, according to the recommendations, according to USPSTF, we want to have 8 sessions over 12 weeks, greater than 12 sessions per year, 6 months. Often the programs last 6 months to a year. They can be delivered by physicians or trained non-physician staff and should include diet, physical activity, and evidence-based behavioral strategies. So diabetes prevention program curriculum is one. There's also model IBT for specifically for obesity. And this is really important, because we don't really give enough importance to what does an intensive lifestyle change program look like. And it's important to remember that this is not for South Asians specifically, right? And I'll talk a little bit about that. But imagine giving someone 2 milligrams of atorvastatin and saying, oh, like we gave them 2 milligrams of atorvastatin, their cholesterol didn't go down. Then I guess cholesterol medicine doesn't work, right? Like we have to give people the appropriate dose of lifestyle intervention. So this is just not the narrative review that I co-wrote along with some other leaders in the field related to lifestyle medicine for the treatment of obesity. So if you're interested in kind of looking at what lifestyle intervention looks like in obesity now, this is something that we just have it's open access, lots of useful tables meant to be more, kind of a handbook. So besides the session cadence and things like this, what should a lifestyle change program look like? It should have evidence-based behavioral treatment. I could spend an entire day just talking about this, but really, these are the components of evidence-based behavioral treatment. And you want to be very action-oriented and specific in your goal setting. This is my program, the SLIM program, and we use shared medical appointments because access to, insurance-based access to intensive lifestyle intervention is a challenge. We've used we've operationalized CPT codes used for office visits for providing that intensive lifestyle change. So this is the structure of my program. We have 12 visits in a group setting, and we have 3 initial visits and follow-up. And the follow-up is really focused on making sure that people have that maintenance support. We use volumetrics, so kind of reducing calorie density. So this is from Barbara Rolls's work, incredible woman, that I really look up to. But if you look at, say, the 600 calorie food, you incorporate increased water and reduced fat, you can make that same food into a 300 calorie food. These are some resources that can be used. The American College of Lifestyle Medicine has a handout on calorie density, as well as the Full Plate Living Program, which is from the Ardmore Institute of Health. They have some really great resources, and all for free. Just other simple concepts: daily weighing. But also framing this, in the clinically speaking, yes, research shows daily weighing is helpful. Self-monitoring is very helpful. But also, we have a large percentage of our patients who have obesity that have disordered eating and eating disorders. So we want to when we're talking about daily weighing, if they have an eating disorder, then that's going to cause weight gain, right? Or it can cause a worsening of their eating disorder. Importance of maintenance therapy. Maintenance is very, very important. So, you don't want to just say intensive lifestyle change and then bye, right? Like we want to also make sure to provide that continued support. And pharmacotherapy also offers superior weight maintenance. So, some pragmatic studies suggest it's possible to support patients in their weight loss with monthly maintenance sessions. So that's an option, and exercise can assist with and augment weight maintenance. Okay, physical activity in those with obesity should really be encouraged for its benefits outside of weight loss. Now, I can't say this is necessarily the case for South Asians, but this is what the physical activity guidelines for Americans at this point recommends. And exercise does not necessarily drive weight loss. Exercise has a lot of benefits. It's important for cardiovascular disease health, promoting weight maintenance, not weight loss, right? So, really we should encourage increasing gradually and, to avoid injury, and continue to encourage, but really important to understand that it does not necessarily drive weight loss. Okay, so now where did GLP, so this is kind of contextualizing where the evidence is, what the expectations are, what does lifestyle change look like. Now where do GLP-1s fit in? Okay, so GLP-1s are these, revolutionary therapies, right? So, we have indications for semaglutide for cardiovascular disease, for metabolically associated steatohepatitis, for chronic kidney disease. We have incredible expectations for so 5 to 10% weight loss for lifestyle change, right? 10 to 12% for orforglipron, most recently approved. Semaglutide, 15 to 16% weight loss, 20% weight loss for tirzepatide. What about and so this is this is the comparison, right? So that 5 to 10% weight loss. Now, we have to, why is that important? Weight regain may be due to persistent metabolic adaptations. So you have to make, once you have somebody go through a lifestyle change program, they might have weight regain. They might also have a plateau around this 5 to 10% weight loss. There's also, and in order to impact things like obstructive sleep apnea, fatty liver disease, you need something like 15 to 20% weight loss, right? What about for South Asians? Okay, so there was there's a meta-analysis just last year, 8 cardiovascular outcome trials. About 30% risk reduction for major adverse cardiovascular events in Asians, whereas for Caucasians, 15% risk reduction in hazard ratio. And then there's a scientific statement out there: South Asians may exhibit better response to incretin-based therapies compared to sulfonylureas and metformin. So, generally speaking, GLP-1s are probably a better choice for us. There has been a study, for example, with liraglutide that actually improvement in visceral adiposity in South Asian participants. So useful. Okay, so GLP-1s are fantastic. Hopefully I've kind of laid the foundation to say that it doesn't, that lifestyle change is still necessary despite GLP-1s, but can they help? Can they augment? Well, so this is data from the SURMOUNT-3 study. So in the SURMOUNT-1 study for tirzepatide, which provides about 20% weight loss, that's what you saw. You saw 20% weight loss at the 72-week mark. But in SURMOUNT-3, what they did was they took a subset of people who lost 5% of their initial body weight using intensive lifestyle intervention, and then they added tirzepatide. Those people lost 25% weight loss. This is the highest weight loss that we've seen outside of bariatric surgery, except for, I think tirzepatide at 88 weeks was 82 weeks or 88 weeks was what showed about the same weight loss, but that's just a longer follow-up, right? So it's really impressive results. We are going to see higher weight loss than this with upcoming agents, but this is really important. Also, there might be additive benefits. So this is the Million Veterans Program. So they took out of this roughly million participants, 98,000 with type 2 diabetes that were on a GLP-1 receptor agonist. And what they sort of assessed everyone's lifestyle change habits at one single time point, eight different lifestyle change habits. And they found when these people who were taking a GLP-1 receptor agonist, they were adhering to 8 low-risk lifestyle change habits. There were 60% lower major adverse cardiovascular event, and GLP-1 RA alone, 16% lower MACE risk, right, compared to the non-lifestyle change folks. And those who maybe 6 to 8 low-risk lifestyle factors plus GLP-1 RA, 43% lower risk of major adverse cardiovascular events. So you can see this additive benefit that people have. Okay, muscle loss, big discussion. So, there is muscle loss from GLP-1 receptor agonists. The clinical significance of this muscle loss is not very clear at this point. Muscle quality might be better. We don't know. It is better, but we don't know if it doesn't mean anything, that some people lose weight, lose muscle. So, I think higher risk groups are important. Interestingly, people with type 2 diabetes are a higher risk group for muscle loss, older adults, postmenopause. So we want to try to encourage slow weight loss if possible. We know that rapid weight loss can, worsen muscle loss. So, this is something that is being discussed. Resistance, I will say this is not, the evidence is very early on this, right? So this is cautiously provided advice, take with a grain of metaphorical salt, if you will, again. Resistance exercise is incredibly important. So, and more important than protein intake. Protein, I mean, we are living in a golden age of ultra processed protein products. So just but I say that somewhat tongue in cheek. I think at the end of the day we have to be practical. Our patients might need the help of those things, but protein without resistance exercise is not adequate. What kind of protein should we be using? 1.2 grams per kilogram of 1.2 to 1.6 grams per kilogram of adjusted body weight or ideal body weight at a or weight at my colleague Michelle Hauser here at Stanford. She uses weight at a BMI of 24.5. So these are and the reason for that is that adipose tissue is it doesn't really require as much protein. And so, if you do now, you hear things like 2 grams per kilogram of actual body weight. And this is, think about the calories that you were replacing when what kinds of foods you're using. So this is a graphic from a multi-society advisory that I was involved in. We called it an advisory because it's not a guideline, not an expert consensus statement, but we recognized that there was a vacuum here in terms of, what was it that people should be doing. So, we talked about basically nutritional priorities to support GLP-1 receptor agonists. We talked about the importance of preservation of muscle and bone mass, managing the GI side effects, preventing and mitigating the nutrient deficiencies that could occur. So, really at the end of the day, hopefully I've convinced you that GLP-1 receptor agonists should not be prescribed in a lifestyle medicine vacuum. This is my daughter's first birthday, and we called it the Better World Bash. We focused on incorporating lots of lifestyle change. We had a healthy potluck. And so, I think the importance of community and culture is really key. And hopefully, we can work toward a better future. So thanks, everybody.
You can hold on to this because you're going to still answer questions. Thank you. Okay, thank you so much, Dr. Sannidhi, for this very balanced and insightful discussion. Just kind of talking about the entire integrative approach, I had a question for you on, so there's been a debate around starting GLP-1 receptor agonists early in South Asians before diabetes develops. How do you counsel patients on early use versus long-term concerns? And then do you view GLP-1s as a lifelong commitment or more as a temporary metabolic jumpstart? Kind of with an intensive lifestyle change and then titrating off safely.
Yeah, I think the first question is very relevant for you because as a pediatrician, you must be thinking about this a lot. I think it's just like with anything else, it's a risk-benefit discussion. I think, if you have, I think it's really important to think about with obesity. Say somebody has a BMI has a weight of 200 right now, and then they gain 20 pounds in 2 months. And now 15% of 200 is going to be 170, right? 15% of 220 is something like 190. So you're starting at a higher baseline now. In terms of what you can come down to is going to be higher. So that carries with it additional cardiometabolic risk. And basically what you're trying to do, and the good thing about, a young person is that they can really increase their exercise and, maximize their bone health from an early age. So I do think that to me the overall risk benefit is a conversation, but it's definitely individualized, right? You have somebody who's maybe disabled and sedentary, they're going to have a higher risk for bone loss. If they're on chronic steroids, even more chronic, risk for bone loss. So I think it's an individualized discussion. With regard to the jumpstart, I'm really glad you asked that question because GLP-1 receptor agonists are not a jumpstart, and so it's a very important thing to know. The way I frame it is that if you are thinking about starting on a GLP-1 receptor agonist, you should have every expectation that you will be on it for the rest of your life. In practice, that's the research, and not just for GLP-1 receptor agonists, for all anti-obesity medications or obesity management medications, or some different terms. But we see that when the medication is taken away, the weight comes back. So very, very important consideration. And, there's different ways of thinking about this. In the real world, we're starting to see there's some small studies that have, people kind of publishing conference abstracts where they're saying they're seeing in the real world, like, oh, if we wean the GLP-1 receptor agonist down, maybe we're able to keep the weight off for longer. But that still doesn't address the cardiometabolic benefit that GLP-1 have independently, right? We're also seeing people say that they're able to work with their patients to have a less frequent dosing schedule, like maybe every 2 weeks, every month, even for some people who responded really well. So, we're going to find out more about that, I think, once there's more, real world data. But for now, the conversation should very much be, you should expect to always be on it.
Thank you.
What do you
One
do
question.
when you plateau
Uh-huh.
on your GLP-1? So when you're at the maximum dose,
Uh-huh.
and at some point you just plateau. And even if you've incorporated exercise and
Yeah.
lifestyle management, but for someone who looks at food and puts on weight, and you're absolutely right. When I did come off a GLP-1, the weight came back.
Yeah.
So, any thoughts on that?
Yeah, I mean, there's an argument for so it's important to look at what other medications you're on and seeing if they have a weight potentiating effect. So to reduce that, so some really common ones are calcium channel blockers like amlodipine or beta blockers. So those things that we don't even think about, but also it's important to look at. It's also there's an argument to be made for layering on other other weight management medications. There is also for very uncontrolled diabetes, and some would argue even less than that bariatric surgery, which comes with its own risk benefit discussion.
Thank you so much, Dr. Sannidhi. Okay, so we're going to move along. You're going to be here, right? You're going to be here for a while. So I'm sure that Dr. Sannidhi will have lots of questions, so you'll have your opportunity to ask her as well.
Leave this here. I don't know how to turn it off.
Okay, that's okay. Me either. Okay. All right. So